Okay. Welcome, everybody, to our experience. This is a holiday edition. It is July 4th week. So we're taking the opportunity to talk to one of our favorite people in government, or maybe formerly in government. But Admiral Pam Schweitzer is here with us today on the podcast. I'm Chad Wurz, next to my partner here, Tom Hansel. And I'm going to read you the description of this episode, Pam, and then I'll let you take it from there. So the description reads, I don't know if Pamela Schweitzer is the highest ranking pharmacist in the history of the United States, but we're going to ask her. We do know that she was a Rear Admiral, Chief Pharmacy Officer, and Assistant Surgeon General in the U.S. Public Health Service. Pam's career has taken her from the remote Indian reservations in South Dakota and Arizona to a leadership role working to improve health and pharmacy practice nationally. So, Pam, I'll let you take it from there. First, where are you the highest ranking pharmacist in history?
A female.
Okay.
Female.
All right.
Female pharmacist.
All right.
Because I was number 10. I was a chief pharmacist officer in the U.S. Public Health Service Commission Corps. I'm number 10. And so there were 9 people before me. They were male. I was the first female in that role. And still, there are number 12 now. There was another number 11 and number 12 are guys too. I'm hoping there'll be a future number 13 or 14 that'll be a female.
Well, I mean, it's such an awesome thing, and we're really privileged to have you here. And I know you've been so active with ASCP and with everything since the COVID pandemic, and your work in rural and urban health and underserved populations goes without saying, and we're just thrilled to have you here. So just start off and give us who is Pamela Schweitzer?
Well, I'll just say right now, I just fell into this public health and working with people that are just, not only that, but in pharmacy too, people that are just passionate about making a difference in people's lives. You know, we get into this and it was never a job for me. It was a way of life. And that's why, since I've been retired now, 6 years, I can't stop. It's really, really hard to stop, to stay involved and to know how things kind of work together. So I started out, I did first 19 years. I did a residency first. I was from California, went to UCSF. Then I did my first duty station was Pine Ridge, South Dakota. And that's actually what changed me. When I went there working with these physicians and nurses and all these different disciplines and seeing how passionate they were trying to improve care, but we worked as a team. We really worked. That's where I kind of saw how working as a team really works together. Worked as a team. And then they exposed me to public health, which is really about prevention. And that was before, I could never tell you what public health was beforehand, but we were working on hepatitis A and tuberculosis, people wearing car seats, just things like that. And I was the health promotion disease prevention coordinator for the particular, they call it service unit or reservation. So that was right out of my residency. So that influenced me a lot. I did some time in the VA. Then I went from there to the VA because wanted to be a little bit closer to home. Loved working there. And they're the ones, I give them full credit for a lot of my leadership training. They saw something in me. The director of the VA saw something in me, sent me to a lot of leadership training. I was a pharmacy director in the VA. And I just happened to be there when John Ogden, he was the one in charge. I don't know if you know him or not. Anyway, he was there. They were getting clinical programs off the ground in the VA. And I was there right in the beginning. And I was right in the beginning with all the automation and the mail order and just all of that technology. And it couldn't have been a better time. I got exposed to all that really early on. That kind of just, the rest of that carried my career. So, and then I spent the last part after I was in back to Indian Health Service, working on national programs, getting involved in policy at the national level, learning how HHS worked, all the different federal agencies. And in the U.S. Public Health Service Commission Corps, there were about 1,400 pharmacy officers at the time scattered in all these different federal agencies. So I had a connection almost everywhere, the CDC, then FDA and NIH and HRSA, all these Fed acronym, all the initials, almost everywhere, working on these cutting edge programs. And, just having that exposure, being around them all. And getting together with them and being deployed with them, getting to know everybody, it really made a difference. Just being boots on the ground, being in part of a lot of these initiatives. So when COVID came along, we sort of, I think part of my whole career is really about, I see how policy changes are made. And it's not good when just a couple people have an opinion. We've really got to expand and make sure everybody's voice is heard. That's why I reach out to you, Chad, a little bit, to be able to make sure that, we've always forget that we got to make sure the seniors are included. We got to make sure rural is included. We got to make sure. And because I've seen the big picture now, I can use my voice more to make sure that the voices are heard, because otherwise some of these policy changes, and I experienced it when I was in Indian Health, they'd make these policy changes. Wait a second, you made this doesn't make sense for us. That's how I first started getting involved, and we had to fix and change things. So I just happened to be around a lot of these passionate people. It's never been a job for me. It's something I love more than anything. I'll do it till the day I die.
Well, that's so great. No, it's awesome. And I'm glad that you brought up, seeing it from the other side, seeing it from the government side. Because I think what's hard when you're talking to pharmacists is they don't see it from the government side, the agency side. And when we have somebody, we like to think we have somebody on the inside, like you're on the inside for us as pharmacists, and you can see the gaps and where the soft spots are that pharmacists can push and gain some traction versus where they can't and end up, running into a brick wall or a policy that the agency or the government's unwilling to change. And I think that's really important. So what would you say right now today? And I think it's funny that you said you've been retired for 6 years. I've only, I think, known you retired. And I can tell you're one of the busiest people I know, and especially retired. So I think that's awesome. But what would you say to pharmacists today, like right now, July 4th, 2024, what should we be thinking about as it relates to policy and government, and where are those soft spots and gaps that we should be pushing?
So this is why I can talk, because it's my opinion. This is going to be my opinion, and I don't have to represent anybody. I worry a lot. What drives me every day is the young people, our children, the grandchildren, and what they're experiencing right now, and what even seniors are experiencing. Because I have more time than I have chance to hear people's stories and what they're going through and dealing with the medical system. And patients need to be heard, what they're going through. And I'm going to share a personal story right now. It's about just my mom. I went through, when you knew me, it's since my mom passed away here in the last six years ago. She was going through, she had dementia, she had Alzheimer's, and we knew she was progressing. She was getting bad. Well, she didn't have any health problems. And so I couldn't get any help for her. The medical system would not help me. And it just frustrated the heck out of me. And I went and I leveraged every connection I had everywhere. And of course I had to push hard to find out. And I'll give you an example. Just, she gets a UTI, they said, well, we can't treat her because even though she was in an assisted living home, we can't treat her because we need to have her come in and test. And I go, yeah, but she doesn't travel. Every time we put her in a car, she falls and she gets cut and we go to the ER. We kept on doing this a lot. So, and I go, can't you just prescribe it? Nope, we can't. That's the rules. Like, come on. Like those kind of things drove me crazy. I had a lot of that happen and I still hear it to this day. I'll be honest with you. So I can take now, we need to package these up, and we can't just say that's the rule. We've got to I think pharmacists are in a good point, use their voice, use your clout, use your expertise to be able to push back a little bit and say, wait a second, this isn't right. We need to fix this, because it's so easy just to let things go, and that's the way it goes. Almost every single time I touch the medical system now, I'm analyzing it from that perspective, because it's like, this needs to be fixed. Everybody's doing their job, but the outcome for the patient is not correct. And part of it is we're not listening to what's important to the patient, what's important to the family. And so I think there needs to be more pushback. So you're asking me a little bit about what I think needs to happen. I think right now, just the way healthcare is going, if we're just trying to line everybody up and try to make things happen, just because it's more easier and more efficient for us. We've got to rethink that. So it all comes back to payment. I think we need to redesign how payment is, how we pay for these things. It needs to be totally revamped so that we're incentivized to do the right thing to help patients. So you do have an outcome, and it's the outcome from their perspective, not from our perspective, if that makes sense.
For sure.
So it's a revamp of everything, and you'll see what I'm putzing on. I putz on these things because we do need to change it. And the thing is that what drives everything in our country really is profit and all these other things. And so people aren't aligned in this area yet. So we've got to make it so there is incentives so people do jump into this to try to actually help prevent things versus just focused on treatment. It's treatment, it's revenue generation. That's what everybody seems to be on, and we forget. A book that I read, you're going to get me going here. The book that I read recently, and I should give it to you. Maybe I emailed you. I can't remember. It's called Fragmented. It was about this. Did you read it? Did you know what I'm talking about?
I'll look it up.
Yeah, look it up. Fragmented. And she just talked about going from the hospital to like a post-acute care and just transfer of information, the medication list, and just the labs, and just going to all the different providers. And it was a physician. And finally, the light bulb kind of turned on. Wait a second, this is something really wrong with this. Everybody's doing their job, but yet the patient is the one that's having to figure all this stuff out. So what I'm really hoping is that we can't just let it go. We need some people speaking up. Yep. Everybody really should be speaking up and saying, wait a second, let's sit and try to figure out how to fix that. And how you fix that is you get all the stakeholders together and they agree that we've got to do something better. We have to do it better, and that you can solve it. If you put energy into anything, everything could be fixed. I honestly believe that. So I don't know. Does that help a little bit?
That's great.
Yeah. No, certainly. And Pam, I know that you worked with NCPA on Innovation Center. Am I saying that right? And then
I'm on their foundation. The foundation, they have a foundation.
And with that, and you mentioned the innovation and automation technology that you were doing early in your career, and I know that you worked on the board at Tabula Rasa, and they certainly were very pioneering when it came to kind of bridging that gap of communication, especially in the PACE type of resident or patient. Kind of with your background of all these different entities and coming from different angles, what do you believe that where the gaps are on that technology? What do you believe the gaps are of actually taking care of those rural patients, the patients that can't get out of bed, the patients that obviously might not even have a primary care physician in their local town to be able to see? Where do you see that we've accomplished and what we need to accomplish over the next few years to kind of meet those patients where they're at, which is mostly at home?
Well, you probably know about the Passio project, Chad. Do you know about that?
Yep.
So Shelley's pulled me into this. So I'm kind of helping with that as much as I can. And so where the gaps are is really kind of focused on all the players being part of it. So you'll get the EHRs, some of them do it, but then it can't be received. Being able to communicate and talking the same language. It's moving right now, probably not moving fast enough. Money makes it move faster, just so you know. Funding, incentives, having outcomes, deadlines, that makes it move faster. And not everybody, staffing, these are projects that are really, really complicated, and you need the right skill set to even know what to do. Like moving to a different IT system is very, very complex, and it takes a long time, and you have to have the right people transitioning and training and being part of how to implement. And I did that for 4 years or so, and I know how complicated it was, and it takes many years to kind of get that down. You watch some of the systems, people have to be embedded in it. My son, by the way, works in they're implementing a system right now. He's an infusion nurse, but he worked in long-term care, nursing homes and stuff like that for a while. He would talk about transitions and learning new systems. It's very stressful to learn all of that. And it has to go at a certain pace so that patients don't get hurt. And everybody's got to be engaged and be part of it. If you're leaving somebody out, then it's not going to be effective. And I think there needs to be some funding provided on the places that aren't normally seen, in the a lot of community areas, being able to have them tap into it. So my new thing is, if this is going to happen, national might be able to help provide some overall structure, but really what's going to drive change is at the community level. And when you get communities together that all decide, let's get this changed. And when I say community, it could be a town, a county, at a smaller level, not big national, because the people are going to make that change. They're the ones that are going to drive and make that change, and coming together and working and figuring this out together. And anyway, that's kind of what I think. So you're right. The things that I mentioned, CPSN is a model. They've done innovative things. Those kind of projects need to keep going, keep pushing on those kind of projects, and then getting those out there so people can see them. Because once you see some movement in there, let's get it go faster. That's where you see the money go. Let's move it quicker. Let's scale it right now. So I like all that. And then the same thing with Tabula Rasa, the work that they do in the PACE program and the improvement they do, with that population, with the seniors, I think is really good. Those kind of programs right there need to get out and then and share it with everybody. And it shouldn't just be a few people doing it. It needs to be more than one company doing it.
Yeah, I think PACE is a great example of something that needs to expand, because it addresses the gap in somebody that can't really be at home with traditional services and doesn't want to be or shouldn't be or can't be in a skilled nursing facility on the other end of that. It's that person that's stuck in the middle. To some degree, just like your story about your mother, it's that. It's, she's otherwise healthy. She has this one issue that it is dramatically affected her quality of life, her ability to be on her own, and we don't have a service model for that. The service model for that is, I don't understand why she can't walk to the corner drugstore and get her medications filled. Well, obviously she can't. So how do we make sure that those services that, we do so well in these other settings like PACE, like long-term care, how do we get them to the people that need them that, again, they want to live at home. Nobody wants to go to a nursing home, but they're complicated enough that they need compliance packaging. They need oversight. They need emergency delivery when they need an emergency delivery, 24 hours a day, 7 days a week. All of those services that we traditionally apply to either a hospital setting or a nursing home setting, there's a group of people that are going to need those, that are going to live at home. And we have all kinds of fancy technology that's coming, and that's all fine and good. But at the end of the day, we have to take care of people in their home, and it means advanced services. And we can't allow payers to say, well, they live at home, so we're just paying, the dispensing fee and the rates that we normally pay somebody that goes to the corner drugstore. Like, it doesn't support the system. And there has to be change there to allow for that. And as intuitive as it sounds, taking care of somebody at home is probably a lot less expensive than taking care of them in a nursing home. But the people that control those piles of money that support that aren't willing to give up their pile of money to save money in another bucket. And that's the problem. And that's, I think, where you get to your fragmented environment.
Totally agree. And just on that note, it was kind of cute because when I'd go visit my mom, we have to go to the pharmacy. So I take her to the pharmacy and I go up, okay. And she would go up there and she goes, they'd ask her, can I have your date of birth? And I just would look at them and I go, I'll tell you her last name. And I said, and you need to look at the medication that she's on. She doesn't know her date of birth. My mom didn't know her date of birth. Right. But it was kind of funny because like all those kind of things, she wouldn't have known how to, like the money, she didn't even know how to count money. You just take what you need. It was that kind of thing. So we had the fire department actually, because it was in a rural community, rural town. The fire department would go by and check on her. That's what would have done because I know, that's not good. I mean, it's good that there's a fire department.
It speaks to your idea about, the communities have to help solve this problem because that's a community problem.
Right. For sure. Right,
But
right.
there's millions of those type of people that need that type of care that might not have
Yeah,
a daughter living close by or fire department willing to kind of pitch
right.
in. And so, I think we depend upon the federal government to make a change, especially when it comes down to CMS and reimbursement. We complain often about reimbursement. In our case this is a long-term care needed patient. They just happen to not live in a nursing home, right? They live in a rural community or live at home. And so, we bang on those walls begging and pleading for reimbursement. And yes, there's obviously self-interest there, but there's also the fact that we really have patients that are abandoned, that are in great need. And in my opinion, unless the state or federal government does something to kind of close that gap, I'm not quite sure just how many fire or police departments are going to be able to fill those gaps in.
You're stressing something somewhere is getting stressed.
Not doing what they're supposed to
Right.
be doing.
So this is one thing that really helps a lot, and I'm putting on my ex-CMS hat right now, is listening, hearing patient stories, gathering these stories. So pharmacists really that's been my latest thing. You guys, if you get a good story,
We need
you
stories.
package it. We changed, by the way, something in Virginia because we got a patient story and I got I didn't prompt what they were saying. I just took what they said and made sure it got elevated. But if we can elevate the family story, the patient stories, that gets everybody's attention. If there's a way we can capture some of these instead of just the industry trying to push things, because I'll be honest with you, when you're sitting there and everybody's coming and at you, you know what I'm getting at. The patient stories are more powerful. One good patient story can actually make a change, permanent
Stories
change.
are important, and I think one thing that I think will be the underbelly of our patient-specific stories is the fact that all of us are going to have our own story of a challenge, just like you have with your mom. All of us have parents. Some of us have grandparents that have experienced some of these challenges in healthcare, and it's going to be so frequent because of the vast numbers of people in the age group of over 65 that it's going to be less difficult to explain, if that makes sense. Because I'm going to tell a story, and that congressperson, that agency person on the other end is going to go, the same thing happened to my mom.
Yeah.
And all of a sudden you're going to get traction where you might not have gotten it before. So, that's kind of a Deus ex machina kind of solution because you're counting on that happening, but you still need to build those very good stories from your practice and share those so that we can take those and have them be the spark that sets the fire for change at the political level, at the government level.
Right. And especially taking those stories and having them, wherever the person lives and making sure that their legislature folks know about it. They know that story. And if that person using their voice, it makes it different. They want to represent their constituents and those work really well too in their setting.
Well,
But
Pam,
anyway, I agree.
This has been awesome. Again, this is our July 4th episode. So, yay, America and our independence. I mean, I'm thrilled that you've been on, and I'm thrilled we talked about things that are so, they're not unique to America, the dealing with an aging population, but they are something that this country is going to have to face in the short term, midterm, and long term of the next 5 to 40 years, because we have a lot of healthcare that we're going to have to figure out how to provide in new, innovative ways and afford in new, innovative ways. And it's really upon us at this point.
And I just, I agree. And I just want to do a shout out because July 4th, that's Independence Day. And, we feel very patriotic. By the way, I go to baseball games. We have season tickets. That's one of the things that I've been doing since I retired.
My son and I do the same thing.
I love going to the baseball game. I love when the Air Force flies over. It is so patriotic. And the fireworks go off. And there's always a section during the game where they have all the uniform, all the military stand up and be recognized. And I just want to do a shout out to all my military colleagues and all the uniform services, eight of them that are out there that are serving selflessly, 24/7 out there for our country. So, well, thank you.
And thanks to you, it needs to be said, serving our country as a pharmacist and representing our voice and making sure that, pharmacist is heard and understood, not because, again, selfish reasons, but because we're an integral part of the healthcare system and we represent our communities and our patients as well. So thank you, Admiral Pam, for what you've spent your life doing.
And thank you for answering the question. We can now say confidently that you are a top 10 highest ranked pharmacist of all time and the number one highest ranked female pharmacist of all time. And that's awesome. So thanks so much.
Awesome.
Thanks for being here.
Thanks for doing this too.
Yeah, absolutely. All right, everybody. We will see you next week with a new episode of Our Experience.